So, good afternoon, everyone, and a very warm welcome to the 20th webinar in the series of webinars by Patient Support Group of ISBMT. And since BMT, I would say it's not all about science. So, today we are going to talk about a very important non-scientific aspect of the transplant journey that our patients face. So BMT, apart from being physically challenging, it can be emotionally challenging too. And so today we'll be talking about the psychological impact of BMT on patients and their caregivers. And we'll learn about the ways how to support them, how to care for their emotional and mental well-being. So, before we go on with the first session, just to briefly introduce the patient support group members, can we go back one or two slides? Yeah. So, the core members of the patient support group are Dr. Venkatesh from Aurangabad, me, myself, then Miss Ria Daruwala, who is also supposed to be our esteemed speaker today, and Sister Suman, Miss Suman from Tata Actrek, and Dr. Santosh, who is Professor and Head, Department of Medical Oncology at Ramaiah Institute of Oncology. And we are very privileged to have mentors like Dr. Revati Ma'am, Dr. Naveen Khatri, and Dr. Tapan Saikia, under whose guidance this initiative is still continuing. So we will start with the first session, which is a talk by Ms. Ria Daruwala. Ms. Ria Daruwala is consultant psycho-oncologist at Narayana Health, Bangalore. Over to you, Ria.
Thank you, Dr. Silky. I'll just share my screen. Can you see it?
Yes.
Yes.
Okay. So, thank you for inviting me and giving me the chance to do this. Quickly go through the role of a psychologist in transplant today. So, basically, when we talk about bone marrow transplant, we have to kind of recognize that it's not just a medical procedure, and it's fundamentally a biopsychosocial experience. So for many patients, BMT brings a combination of challenges that extends beyond the physical illness, and this includes emotional aspects as well. So there is often significant emotional issues like uncertainty about outcomes, about survival, prognosis. There is a disruption of daily life and roles where many patients may have to stop work. There is a change in the social environment, and families also recognize and change, caregiving demands. So in addition to this, of course, there is, prolonged physical and emotional strain in terms of isolation because of BMT, long recovery periods, and of course, very intensive treatment regimens. So you might wonder that, in all of this, why does psychology matter? Right? Because research does show that it is clinically relevant because it's directly linked to patient outcomes. So when patients are clinically well and emotionally well, there is better adherence to treatment, there is reduced distress due to the symptom burden, and there is improved quality of life and adjustment over time. So what is psycho-oncology, and what do we do? So basically it is a specialized field that addresses psychological, social, and behavioral aspects of not just cancer care but any chronic illness, right? And how these factors influence your care and outcomes over time. So in the context of BMT, most often psychologists and psycho-oncologists are integrated into the multidisciplinary team so that they can take care of emotional well-being, aspects of coping and resilience, and as well as communication decision making amongst patients while they go through their transplant trajectory. It's also important to note that usually psychologists are not involved at one particular time point, but are involved throughout the disease and treatment trajectory so that we can cater to various issues at various points in time, right? So, if you are to think of it in what a psychologist does in various steps of the BMT journey, in the pre-transplant phase where patients are basically navigating lots of medical evaluations, preparations for transplant, and complex decision-making processes, where there are questions about donors, what kind of transplant is going to happen, etc. There is often a lot of uncertainty. There is a lot of information overload which may be overwhelming, and there's also a lot of anticipatory anxiety about what's going to happen, how are we going to deal with this, right? So in this process psychologists can help. During the transplant hospitalization, we know that this is a very high intensity treatment phase, where patients experience isolation because of infection prevention measures. There are physical side effects of the treatment. Sometimes there is sense of loss of independence and autonomy because most things are being handled by the medical team. And of course, this has significant impact on emotional well-being of patients, right? Early recovery, we would mostly think that patients do well and are excited to be going home. They are, but often there is a new adjustment that is required because um, treatment post treatment there is still residual effects, so things like fatigue, re-engaging with normal life, going back to your roles and responsibilities also takes some amount of adjustment which may not happen optimally for everyone, and this is another place where psychologists might step in. Now, in terms of long-term survivorship, also psychologists have a role to play because we can monitor reintegration and help with any challenges that come with that as well, right? So it's critical to basically recognize that each stage has very distinct emotional and psychological effects, and each of these has a different way in which they are treated and intervened. So the process is very dynamic, and the psychological issues are phase specific rather than kind of uniform across the entire treatment trajectory. So, based on research and experience, basically, there are some common emotional experiences that happen to anybody undergoing the BMT process, right? So, one is, of course, that there could be anxiety related to procedures, complications, and uncertainty about the entire process, right? The second is that there is a sense of loss of control because most patients become increasingly dependent on the medical team as well as their caregiver, even for basic needs, right? So this shift sometimes can be particularly difficult for adolescents or adults, especially if they are used to being very independent, right? The other thing is that there could be isolation, and this isolation is usually prolonged and for infection precautions, but this limits social contact, which can contribute to feelings of loneliness and just general disconnection from society. We can also have mood fluctuations, irritability, because of the treatment, and because of other psychological stressors like fatigue, sleep disturbances, etc., right? And then of course there can be concerns about identity, body image, and future, because often there are changes in the way that patients look, and there could be concerns about, will I be able to go back to work normally, go back to my roles as a parent, as a partner, etc. So these concerns, however, are not considered abnormal. They are expected. They are adaptive responses to any stressful situation, and they most often resolve over time with the right intervention. So when we talk about psychological challenges, I've divided it into challenges that patients face and caregivers face. So in terms of patients, there could be very real concerns such as the fear of complications like GVHD, the fear of relapse in malignant conditions, and of course, the fear of mortality, considering that these are very high intensity and rigorous treatment regimens. right? At the same time, there is an increased physical symptom burden. So there could be physical symptoms like fatigue, sleep disturbances, mucositis, vomiting, etc. And these often have an impact on mood as well. Besides this, like I said, there is prolonged hospitalization, sometimes for approximately a month, which means that you have to be isolated from everybody, and you're usually just with one caregiver in a ward, which can also be quite emotionally taxing, right? There's also a loss of autonomy and role functioning. So often, patients don't get they they lose their sense of independence because everything is being taken care of by the treating team, by the nurses, by the caregivers. And this could be even simple things like taking a bath, or when to eat, what to eat, etc. is usually always decided by someone else, right? And there is a shift in role functioning. So very often patients take a pause on their role. So, for example, parents might, hand over caregiving responsibilities to their partner or to their parents or to someone else. They often have to stop work. So, multiple roles get affected. And then, of course, that there is difficulty transitioning back to normal life once the process is done. So, what's important here is to see that the challenges are multifactorial. So, they affect emotions, they affect biological health, they affect social functioning, and they evolve over time. So interventions also are designed to cater to this and evolve with the patient. Now, in terms of caregivers, we often overlook them, but it's important to know that caregivers are usually deeply impacted themselves because they are kind of deeply entrenched in the process of caregiving, right? So, caregivers often have to have continuous vigilance and responsibility for care, which means that things like sleep, and appetite are also affected because they spend majority of their time caring for the person who's undergoing transplant, right? There could be emotional distress, there could be anticipatory anxiety, and there could be a lot of uncertainty. So it could be things like, is the treatment working? Will will this person get okay? How long is it going to take? Right? And usually they have to hold it on all in because we are used to kind of saying that caregivers should be strong for their patients, right? And that's a lot of pressure to put on someone. They also very often manage the financial strain and the logistic burden. So how do we manage this financially? What do we do about other logistical issues like travel, food, childcare, etc.? Right? It all falls on the responsibility of the caregiver. Along with that, like I said, they adapt additional roles. So they may become both mom and dad if one person is in transplant. They may need to become, along with that, care for their children. They may have to cook. They may have to take care of finances, right? So this adds responsibility. And of course, all this compounds into the risk of having burnout and compassion fatigue in the caregiver. So it's essential, as psychologists, what we do is we don't only care for the patient undergoing transplant, but we're also now closely connected for to the caregiver to ensure that overall patients do well, and this helps to optimize outcomes overall. So, like I said, um, if I have to put the role of a psychologist in BMT very briefly, I would say that some of the things that we do is that we engage in screening and structured assessment because this helps us to identify any distress or emotional challenges early on. It helps us to understand various risk levels in patients and families, and then it helps us to tailor make interventions for each person separately, right? It also helps us to provide emotional and behavioral interventions for that particular person. And this could be to address issues like anxiety, mood changes, adjustment difficulties, and any treatment related distress, emotional distress that patients might be facing. Coping skills and coping skills and resilience building is another thing that we often do, where it includes, helping families and patients develop strategies to manage dealing with things like the uncertainty of treatment, tolerating some amount of distress, and just navigating all these various demands that a treatment like BMT poses, right? Overall, there is caregiver and family support, which is just somebody to talk to and somebody to help you through this journey that can often seem very lonely. And in rare circumstances, there could be crisis intervention and end of life support where we help patients transition, into end of life. Um, so, in terms of assessments, I think it's crucial for psychologists also to be included in pre-transplant psychological assessments, which we often do at many centers, because this helps us to evaluate and assess readiness for transplant. And what this helps us to do is basically it helps us to see whether patients understand the procedure and set realistic expectations from BMT. So, for example, if patients have an expectation that 1 month post transplant we're going to be back to completely normal, then somebody needs to normalize that, right? We also aid in coping and psychological resilience. So this helps, kind of tell us how patients manage their stress, and it would also help us predict how they would navigate the process of transplant, right? We evaluate social support and caregiving ability and availability to see how much support is available. Will the caregiver may be able to manage the demands of transplant, and what kind of social support is available to manage all the various other logistical things that they have to put in place. Another important thing is evaluating a past mental health history. So if there is any previous history, a psychiatric history of anxiety, depression, substance use, self-harm, anything like that, we are able to catch it early. For things like substance abuse, we can also initiate de-addiction procedures, which will help make the transplant process easier and prevent the team from any surprises while you're in transplant. So basically, it helps us to identify risk for distress, and it helps in early intervention planning for any psychological issue that may come up. So in terms of preparing families, what we tend to do is that we psychoeducate about various things. So one is, of course, that we prepare them for the emotional challenges during BMT, things like staying in hospital long, how we can deal with this, right? So there are no surprises that come up. The second is to set realistic expectations about what this journey is going to be like. So there is a pre-treatment phase, there's a during treatment phase, and then there's a post-treatment long recovery phase, which is what we emphasize on, and what we can expect during each of these phases. We also address any fears and misconceptions. As you might know, there are several that exist. So for example, there could be misconceptions around simple things, which add burden to families often, and correcting these could be very useful, right? So often when we do this in patients, they say that, oh, that makes it a lot easier because we thought that BMT is going to be like this. So that's particularly helpful. And then what it does, it helps to enhance communication. Very often primary treating teams are very, very busy. So what tends to happen is that psychologists may become like a bridge between the patient, family, and the treating team. So any issues that they might raise, we often take to the treating team to be addressed, right? So during hospitalization, what we do is that we manage acute distress, whether this be in the form of anxiety, panic, sometimes sleep disturbances, right? We help to address isolation and boredom. So for example, very simply in children, it may include engaging them in activities every day, or giving them a task to do, right? This helps. And then interventions, of course, could include multiple things, but during treatment, because we cannot do very intensive interventions, what we generally try to do is we train for relaxation, we use grounding techniques, and then we structure daily routine so that people still have a sense of responsibility and role. And then we support caregivers, of course, during their phase, depending on whatever they need. Post-treatment support, I think, is more intensive, and we have a bigger role to play there. So we aid in adjustment to survivorship, and we manage things like fear of relapse or recurrence. There could be cognitive changes, which we usually assess and then we can rehabilitate for. And then we support reintegration to school or work if there's any issues there, social functioning, and of course, we monitor emotional well-being long term. Right. One of the other things that we do and advocate for is neuropsychological assessments, because we know that there is a risk of cognitive change post-transplant in the long term. So usually a pre-transplant baseline assessment is recommended where we may assess these various areas such as attention, memory, executive functioning. And what it helps us to do is it helps us to understand if there are any pre-existing conditions which exist, if they have received any treatments that may cause long-term effects we know about. And then this helps us to guide rehabilitation post-treatment into survivorship, right? So just very briefly, some of the interventions that we can provide are supportive psychotherapy. We can use more intensive forms like CBT, and then there could be mindfulness and relaxation-based interventions, family and caregiver interventions, and of course, psychoeducation and problem-solving approaches. Now, it's important to note that most of these are tailor-made to each patient. So just like your BMT treatment plan is individualized. Psychological treatment plans and interventions are also individualized based on the patient's need, their symptoms, and kind of what would work for them, right? One of the other things to keep in mind is that, ACT clinics are key where psychologists may play a very prominent role. These are after completion of therapy clinics where we monitor patients throughout life post-treatment. And the rationale for doing this is that they have regular screening of distress as well as functioning, because we know that sometimes long-term effects may persist. There is care which is provided, which is tailor-made based on the level of need of the patient. And of course, then they can be referred to specialized services whenever required, right? So it's usually conducted at key medical milestones. Once a year after that, and of course at any critical transition phase. So for example, a child going into adolescence, an adolescent moving to college, somebody getting married, deciding to have children, any critical milestone in life is usually when we recommend that there should be a follow-up, right? And this ensures continuity of psychosocial care as well as support throughout the trajectory. So very simply put, when should you seek help? If you were to ask, if the patient or the caregiver for that matter notices any persistent symptoms like sadness, anxiety, or distress, any difficulties with coping with the treatment demands like sleep or appetite changes, feeling overwhelmed, hopeless, or having any sort of mood changes which are new, concerns with body image or sexual health, and of course, any strain in relationships within the family, within caregivers, within partners, and then any concerns or challenges in survivorship. So, this is just very broad, but any emotional challenge basically can be addressed by the psychologist, right? So what's important here is that if you flag it early, just like any other concern, it usually helps us to intervene early, and that therefore leads to better outcomes, right? So the key takeaways basically today are that psychological care is integral to BMT care, and it should be part and parcel of it, right? Emotional responses are valid and expected, and these are adaptive. So the reason why I specifically want to highlight this is because several times when psychologists are involved, patients or caregivers often say that we don't have anything wrong with us, right? We don't want to see a mental health professional. But this isn't because there is an issue. It's just to prevent any issue from kind of arising, right? So early assessment and intervention always helps improve outcomes. Both patients and caregivers often require support during the phase of treatment, and That's okay. It's okay to ask for help. And to kind of note that psychologists are equally a part of your care team, just as nurses, doctors, physiotherapists, and other people. So thank you. This is my contact if anybody would like to get in touch. Yeah.
So thank you so much, Ria. So I think you have put everything in a nutshell for our audience, and it was great to listen to you talking about how a patient or a caregiver might feel during the transplant journey, and for putting those feelings particularly into words like fear, anxiety. There can be all kind of emotions that they face during this phase, and how the presence of a psycho-oncologist can help deal with this distress that they face. So we will now move on to the next session, which is a panel discussion. And for the panel discussion today, we have with us Dr. Rishabh Bhardwaj. Dr. Rishabh is a consultant in pediatric hemato-oncology and BMT at MGM Cancer Institute and MGM Healthcare, Chennai. Welcome, Dr. Rishabh. And as panelists, we have with us today Mrs. Preeti Malhotra, who is proud parent of the Maita Malhotra, who has already undergone transplant. So she is here to share her experience. At present, she is center head of a preschool named Kidzone. Sister Sankavi Nagamuthu is also here with us today. She is a assistant clinical nurse at Apollo Cancer Center, Chennai. Then Miss Prasanvika, she's art therapist and art facilitator in Chennai. And Miss Ria, whom you have already heard. So welcome all the panelists, and I hand over to Dr. Rishabh for the panel discussion.
Hi, good afternoon, everyone. I hope you can all hear me clearly. Thank you so much, Dr. Silky, for that very kind introduction of both the moderator and the panelists. So, thank you to the ISBMT support group for considering me worthy enough to moderate such a lovely session. And I mean, it's such an apt program considering that we just recently celebrated World Psycho-Oncology Day on the 9th of April. So, let me just share my screen here, and then we can quickly go ahead. Is everybody able to view the slideshow?
Yes.
Right.
Yeah.
So we've just heard a lovely talk from Miss Ria about the role of psycho-oncology. I mean, not just in transplant, of course, but it encompasses so much across the entire spectrum of hematology and oncology. They are such an integral part of the core team, and it is something which has been coming up over the last
Sorry
few
for the
years.
interruption, sir.
Yeah, sure.
Sir, we can see your screen as in black patches in your screen. Can you please stop share and reshare again?
Sure. Does this work?
Sir, please share your presentation, not entire screen.
Okay. Are you able to see the presentation now?
So we can see the presentation. However, I think because it's on Zoom, we can see the panels of the Zoom also, but those are
Okay.
patched up.
Okay. If I hide the thumbnail video, is this okay now?
Yeah, this is fine, I
Yes,
think.
this is pretty
This is
better.
okay? Yeah.
Yeah.
Okay. So, like I was saying, I mean, psycho-oncology, there's been a lot of talk over the last few years, and it is coming up really nicely, but I do think we have a long way to go. And panels and attempts such as this obviously will go a long way towards increasing access to psycho-oncology care. So after this talk, I just thought we'll go over a couple of common case scenarios which we see as clinicians, and where we do require the help of so many people around us, like the psycho-oncologists, the nurses, we have therapists, who come in and help us, deal with all this on an everyday basis. The first, this is, something which we do see it like, sounds like it's out of a novel, but unfortunately, we do see cases such as this, where people who have, just been recently, entering a new phase of life and unfortunately hit with a, devastating diagnosis. So, for example, a 34-year-old man recently married and now a new father with an infant child, diagnosed with, for example, aplastic anemia, requiring transfusion support. Now, obviously, he has now been counseled for a bone marrow transplant, and this has hit him really hard. So, like a lot of young adults who we know, he's now become withdrawn post the diagnosis. He doesn't really engage much with his family, and obviously this is now having an impact on everyone at home, because it's a very critical period for his wife as well, as a new mother with a baby. She's having to manage both a baby and a husband who has been hit with a diagnosis. So, if I could request Miss Sankavi, who's a nurse, to take this. So, because the nurses are the ones, once we counsel the patients in the OPD, and once we do get them admitted, usually it's the nurses who are their first point of contact, who start with everything, and then the patients, the doubts which the patients don't ask in the OPD, they end up opening up to the nurses who come in. So, Ms. Sankavi, how do you approach a patient who, like, because some of them might open up, they might ask you questions. How do you approach a patient such as this, who you might find emotionally closed off, and how would you approach the caregiver as well, who is so important in this case?
Thank you for the question, sir. So, as a nurse, we learn and develop skill to handle a different situation. When you are dealing with the children, it is different, and when you are dealing with the caregiver, it is different. The most important thing is to remind patients all the times. So, some patient react with the anger, and some patient do not cooperate for the treatment. So, some caregivers are exceptionally cheerful. Some caregivers, when the patient shut down, we should not force them to talk. So instead, we should first focus on being present with them all the time, sir. Sometimes just sitting with them and providing a routine care can help the patient to speak up. So gaining trust and building confidence by showing that we are here to help them and support them. So trust takes time. So until they open up speaking, we need to continue showing the compassionate care. We can also seek help from psychologists or counselors, or the even the family members and the friends who may connect better with them. Um, or else sometimes we can call the previous patient who has been in the similar situations, can come and counsel the family, which we can get the things improve. So we should also acknowledge the caregivers by asking them and helping them they about their well-being, and also offering support, because when we care for the caregivers, we strengthen the patient care as well. So the one main important thing during this process, we must ensure that the physician team is aware of the psychological impact of the treatment is having on the patient, and also the family members.
I think that's really well said, because as clinicians, I think as nurses rather, the amount of time you spend with the patient and family is exponentially more. So nurses do get to hear a lot more, because it's very common for us to, for example, when we go on rounds the next day, the nurses always give us very critical insights, because off hours, has the patient opened up, have they raised any concerns which we might not know of initially. So, like I said, the nurses play such a crucial role, and your inputs are so vital in this case. So, Miss Ria, if you could take this. So, you must have seen a lot of patients like this. Like I said, absolutely. I mean, looking forward to their next phase of life, their whole lives ahead of them. How does a devastating diagnosis like this affect their thoughts about the future? And how do you approach a patient like this, where you need to hold their hand and tell them that, this is not the end, and this is something else which they might just need to pass through for a brighter future. How would you approach this?
Right, thank you, Dr. Rishabh, for that question. I think this is quite common and something that we see quite often. So I think especially for this case that you've spoken about, young father, young person, new father, looking forward to a lot in life, has suddenly now been impacted by something very significant. So usually what we would do is that we would first of all allow people to feel what they're feeling, right? Because very often we push people to adapt very quickly, and sometimes processing information can take time. So allowing them to just process and being there with them. So this could include even having doubts about things like, what if I don't make it, right? So basically addressing both good and bad, because that often offers some amount of comfort, right? So what can psychological impact look like? Like I said, it could look like guilt, it could look like anger, it could look like sadness, it could look like withdrawal in this particular person, right? It could look like somebody just giving up, right? Many different ways. So I think what's important is to allow the person to feel what they're feeling, and then kind of help them work through those emotions. So for a patient like this, like I spoke about earlier, something like a cognitive behavioral therapy approach would work really well, because that kind of helps them figure out how they would cope themselves.
Okay, that's very interesting. That's a very interesting application of CBT, which I'm hearing of. Thank you so much for that. So, do you also, I mean, does gender play a role in your experience? Do you find that men and women respond and react differently, not just initially, but through the treatment as well? And does it change in the way you work with them?
So I think it does sometimes kind of show differently, primarily because of cultural aspects, where in cultures like us, men are more supposed to be strong, they're not supposed to cry. There are a lot of cultural barriers to this, and women often are known to be more emotional, right? But like I said, this is not a one size fits all. So you might find men who open up, and you might find women who don't as well. But it's very individualized. So usually what tends to happen is that if you give anybody, man or woman, enough time and the comfort to be able to open up honestly, that's more crucial. So the way we approach doesn't necessarily change based on the gender. It changes based on what the patient's needs are. So if somebody is open in the beginning, that makes it kind of easier for us. If you said like somebody is a bit closed off, that may require a slightly different approach, but it doesn't necessarily depend on the gender of the person.
That's some really lovely insight. Thank you so much. So moving on, tackling another case of a girl now. So a 9-year-old girl, a healthy, happy school-going child, top of her class, lots of extracurricular activities, doesn't miss school. In the absolute peak of her childhood, and then suddenly, a diagnosis of high-risk leukemia. She's now being counseled for high-dose chemotherapy followed by transplant. Which in itself is very, very challenging. So she undergoes chemotherapy. She's, a lot of the symptoms and a lot of the side effects associated with chemo, like losing her hair. She's obviously going to have to miss school. And this is such a critical phase. Children. It's very hard, but we also know that children are very resilient, and we see that children actually respond after the initial phase. They actually respond really well. It's the parents here who obviously need a lot of support, because I think it's like one diagnosis which no parent ever wants to hear. So if I could request Miss Preeti, it's so lovely to have a parent here, and it's so lovely to be able to hear the actual feelings from the other side. So can you take us through what your initial feelings were, and how psycho-oncology helped you navigate this entire period? We would love to hear your thoughts.
Good afternoon, Doctor, esteemed members of the medical team, and everyone present. Thank you, Doctor, for the question. My daughter was first diagnosed when she was 3 years old. Obviously, there's shock, and it's like we were not able to take the diagnosis. But after that, she relapsed after treatment, after 7 years of treatment, and that was even more heavier. It was like hearing the same storm is coming again. There was disbelief first, then again the same wave of fear, helplessness, anger, exhaustiveness. But I can truly say that the support oncology team gave us, they meant actually everything to us during that period. They were incredibly helpful, not just medically, but also emotionally. They had treated my child earlier too, so I had deep sense of trust in them. I knew in my heart that whatever they will take, whatever decision they take, whatever they do would be in the best interest of my child. That faith gave me strength in some of the most difficult moments. To me, they were nothing less than God's guiding hands.
Was there any point during this where maybe you expected something else, and uh, like maybe did you think like your child would respond in a certain way, and instead your child behaved like I mean, did your child surprise you at any point of time with the way she dealt with everything, because she was only 3 years old? So
Yeah,
were there any doubts in your
definitely.
head as to how she would undergo the entire treatment and how she would respond?
When she was 3 years old and she underwent the treatment, it was more easier at that time. She was small. But then when the relapse happened, she was 12 years old, and that was really difficult for her to take. My child has always been a very calm child otherwise. But when she got the diagnosis, it was like we had not even told her earlier, that she underwent all those things. And she had forgotten it. The only thing she remembered about hospital visits was one nice doctor giving her chocolates, and they would treat her nicely. She had only very good memories, so she didn't know what she had underwent earlier. So when she got the diagnosis at the age of 12, she was just not able to take it, and she surprised us by every behavior of us. Like, she was rebellion to the course she just didn't want to take, and think she was not ready for the BMT. We had to counsel her doctors had to counsel her, and it was really difficult.
And did your child I mean did she engage with a
I'm sorry, doctor,
psycho-oncologist?
I'm not able to hear your question.
Did she engage with a psycho-oncologist when she relapsed and she was 12 years old, pre-teens? It is quite a difficult phase. Did how did psycho-oncology help her, you feel?
Yeah, they were very, as in, they used to talk very nicely to her, and they would motivate her. She loved painting, and she would sit in the hospital and do painting. So they would always motivate her every time they would come, for the routine. Every day when they would come to check her, no, routinely, they would ask her, the Maitha, what have you painted today? And that gave her that sense that daily she needs to paint something. So even if she was not feeling all that well, she would sit up and she would paint, and it would relax her. I would see, like, she would not do that much painting even at home, how much she did in the hospital. And that was really relaxing. Like, painting took her to a different level, and the way the doctors motivated her to do it, that also took her to a different level. The way they would come and they would be, like, this is very nice, that is very nice, I want to take this home today, I want to take that home today. And that just gave her a different strength, and seeing her happy and motivated like that, that gave us a different strength altogether.
Yes, I can understand. I think most of us pediatric oncologists would agree. I think our OPDs are plastered with kids' paintings, and that's a very nice segue, I think, to the next question. Um, um, could I ask Miss Prasanna to take this question, Miss Prasanna, who's an art therapist with us? Children, they can't often articulate fear and loss, especially younger children. So in your experience, how does working with colors help children process what they're going through? And could you walk us through what a session with you might look like?
Yeah, thank you so much for the question, Dr. Rishabh. And before answering the question, I think I need to take a minute to thank Revati ma'am for even considering my work worthy enough to be part of a setup like this. It feels unreal that I'm a part of a panel that does such an important job on an everyday basis. And To put it short, I think it's humbled me in ways I can't put into words. Um, what I do basically is I take pre-drawn sheets. These are already drawn sheets, and the kids are dealing with a lot, right? They're dealing with isolation. They're dealing with the side effects of the treatment, and sometimes they don't open up to the caregiver simply because in a room it's just them and the parent, right? And when they see a third person walking in, not with syringes but something entirely different like colors and like drawings, they get very excited. And I've seen kids open up much better during scenarios where they are just sitting and coloring. And a very important thing our nurse Sankavi said was that there's no pressure for them to color. Like if a kid is not in the mind space to color, I think the very important thing I've understood here is nothing you say is going to change that. You just need to probably offer your presence to them. But I've seen kids navigate very hard periods just post BMT, and when there is an active transfusion happening and then they are sitting down and like coloring. The main thing here is they have a sense of accomplishment, and I feel like that's a very hard thing, especially in a scenario like that where they probably feel really alone and scared. And coloring a small piece of work, and I tell them to also sign their name at the bottom of it. Once they finish doing that and they sign their name, they're very happy and they pose with the artwork very happily. And it's such a small win for them, and it really helps them that way, I feel like.
That sounds great. Can I go back to Miss Ria, please? So we have heard from a parent who has gone through everything, who has actually lived this life. So can we hear your perspective when a parent walks in for the first time, having just received their diagnosis? How do you approach, from the beginning and then through their care, and assuming they're going in for a transplant? What does your approach look like?
Thanks, Dr. Rishabh, for that question. So I think this is very important, and one of the things that we advocate for very strongly is that to be present when the diagnosis is broken, so that we are there at this crucial time point, and also gives parents and families a sense that you are part of the treating team, rather than a stranger walking into the room once it's done, right? So this is something that we routinely practice at our center. So post basically the diagnosis, we often spend time with the family to help them understand what's going on. Most often, many parents actually tell me that the moment we heard the word cancer, we just shut off. We don't know what happened after that. We didn't hear anything that our treating team told us, right? So sometimes it's just about reiterating that information, or telling them that it's okay, you don't have to understand everything right now. We can talk about this again tomorrow and take it one step at a time. So that's of course one. There could be various emotions. Like I said, some people cope extremely well, which is also worrying. Some people are extremely distressed. Some people just need time. Some people cry. Some people have expected it but didn't want to hear it. There could be just multiple reactions based on what happens. So what we tend to do post this is that we're of course part of their treatment journey, right from diagnosis all the way to survivorship. And like I showed you a bit in our PPT, the needs also evolve, right? So we tend to prepare them before something happens, especially like in situations like BMT. The moment the team might be preparing for BMT and the parents are aware of it, we already start working with children. And so we prepare them for the fact that they may be isolated. What can you do? And by then rapport is already built, right? So we're already part of their ecosystem. And I often feel like psychologists become their safe space because they can play with us, they can talk to us, and we spend a lot of time with them. So what tends to happen is they look forward to intervention, during that time. So several times we accompany children into radiation rooms, because they just want a sense of familiarity. And very often, primary treating teams, of course, don't have the luxury of time, to be able to do that. We also use a lot of therapeutic play. So, for example, we have therapeutic dolls where we can show what a cannula insertion looks like, what an NG tube insertion looks like, right? So it kind of reduces the sense of fear, and children are allowed to play with these things, right? So usually these things are considered something that you're not supposed to play with, right? But the moment the child has access to an NG tube and he knows that it's just a tube and I can play it and bend it, there's a sense of fear goes away. So I think it takes a lot of work and preparation, but if we invest in that, children and parents, they both cope very well throughout the treatment trajectory, and that's kind of what support looks like.
No, that's beautifully said. I think you've encapsulated everything. And I think the main takeaway from that is, I think the involvement of the psycho-oncologist right at the beginning, right? Just so everyone is on the same page, and especially the parents know that there is someone who they can fall back on, because it's not always they can, put forth their questions to, their thoughts, their anxieties. Everything cannot be directed at the clinical team. So I think that is a very important takeaway. So thank you for that. And Ms. Preeti, if I can have you back. So what was your experience post-transplant? Like, I mean, we all know that transplant is a very stormy phase, but post-transplant as well, there is quite a lot which is going on with your follow-ups, and there might be an admission for infections, and there will be bone marrow aspirations to make sure your child is in remission. So how did that phase look like for you?
Yeah, after transplant, when the world expects celebration, definitely there's gratitude, but there are a lot more emotions also. There's constant fear, there's anxiety, there's exhaustion. And even on good days, no, even a small symptom gives such a lot of fear. And yeah, like you said, there are so many other things also which continue after the transplant. My child had severe stomach pain after transplant, so she was again readmitted after discharge. So all those things together, they are like a real big burden on us. But once that phase is over, like I saw her recovering, and once that phase was over, I can say it was worth it. I'm really thankful to the entire medical fraternity for instilling that hope. I'm really thankful to Dr. Revati Raj, to the hope team. But yes, there are some memories, and those would be there because that we had so much of anxiety, we were in so much of fear. But yes, it has helped us a lot. The oncology team constantly keeps telling us that everything is okay, and they constantly keep telling you that this needs to be done next and this needs to be done whatever needs to be done, and they explain it so well. So we know with that definitely things are in the right place, and there's no need to fear. It's okay, it's going to be okay, that way.
Because even a year post transplant, when we take up a child for a bone marrow just to check an MRD report, we can see the same anxiety, which these parents face, and they are constantly on tenterhooks. And we really feel for them, because even so far out of transplant, you're still hit back with those same memories. Is my child's MRD going to be negative, etc.? So I think as clinicians, we need to be very cognizant of the fact that, post transplant, we need to, have that little empathy as well, that parents are still not truly out of it. So coming to the last scenario, because post transplant, like I said, there's so much going out. There are a few patients who unfortunately develop complications, like, let's take this elderly 52-year-old who's had chronic GVHD now. So he has fatigue, he has chronic skin GVHD changes, maybe some contractures which have reduced his mobility. And his life, he had built an identity around being a provider. He was very active at home. Now he's taken early retirement. He feels like a burden to his adult children. So if we can go back to Miss Sankavi, so now when you might hear a patient coming in like this and saying that, I did want to undergo treatment, and I feel very happy to have been treated, but I didn't survive to live like this. There is so much of morbidity. How do you deal with these patients? And when they say this, what are you thinking? How do you approach them? And at what point do you feel like, this patient really needs a little more help?
Uh, Sir, it is very difficult to handle this moment actually, and we need to remain patient at this moment. So it is important to understand some patient wants to talk and some wants to listen. So as we nurse, we must be the good listener. Uh, as a nurse, we must be the good listener. So listen actively to understand what are their concern. So and we need to respect and validate their emotional also, and we need to access their emotional state. Once we understand where the patients stand emotionally, so we can plan appropriately what the support they want. So some patient may require medication such as antidepressant, and if they express need for the psychological support or if they show the signs of distress, we can recommend some psychiatrist consultation also. So addressing this feeling early is very crucial, and so that we do not progress into the patient into the severe depression.
Thank you so much for that. So can we go back to Ms. Prasanna Vikafo? So uh, what is your experience? Because, we often associate art with just kids, kids, we all know kids like to draw, kids like to do art, but actually there are a lot of adults who like art as well. And, someone who's gone through this might have just forgotten what it is to, just pick up a paper and a pencil or just some colors. So like, do you believe that there's a role with potential benefits in adults as well?
Yeah, absolutely. I mean, with kids, I work only in hospital setups, but apart from kids, I work with adults on a very regular basis where they engage with art and coloring, and especially if it is something that is very repetitive, right? Like mandala drawing or repeating a pattern and just sitting with that, it has a lot of psychological benefits. And I've worked with adults who have like gone through cancer diagnosis and who are actively in chemotherapy, and they say that it's really helped them. And yeah, I think the feeling as an adult and as a child is very similar. I think it's a sense of accomplishment when you're able to put pen to paper and create something, and it's a reminder during a very hard time that you can put together something and it can turn out looking really beautiful, right? And it's a thought that they hold on to, and it's not just the paper. I think it gets translated into other areas of their life as well. And from what I've observed, whether it's an adult or a child, I think art creates an immediate safe space. There's no pressure for them to keep talking. It immediately puts them in a very comfortable space where they open up by themselves. And I've seen a lot of adults and children do this, where especially in a place like BMT where they come from all over the world, as when they are engaging with art, it's when they open up about how their country looks, or how beautiful it is and what kind of food they eat. And these are not even questions that you're asking them. It's just that you have facilitated an environment which is making art that has put them in a place where they're able to share these things on their own. And it has immense benefits with older patients as well, because the psychological effects are pretty much the same in adults and in children when they deal with art and colors.
Yeah, right. Thank you. I think I completely agree. I think there's a lot of benefits to art therapy in adults as well, and I think a lot of adult colleagues probably might do well in utilizing your experience, and other art therapists. So Miss Preeti, if I could have you back, because like we have said, like you have been someone who's gone through this not once but twice at two different time points. If someone else contacted you at this point, let's say this patient's children contact you and ask, how do we support this patient? What advice would you like to give them, as a family member and as a caregiver? Is there anything that you would like to say to them?
Yes, doctor, I'll tell them that the best thing that you can do for the patient is to be present, not overpowering, just be present. You need to ask, then assume. Sometimes they need help and sometimes they only need space. To the patient's children, Yeah, I would say that just have love and patience. That's all. More than that, it's not needed actually. Because if it's an adult patient, I'm sure they know what they want to do. So you just need to stand there beside them, not over them. You need to support them quietly, respect their independence, remind them that they are not alone. Basically, that's a very important thing. And without making them feeling helpless, you need to give that support without making them feel helpless. You need to tell them it's okay, it's all right. You're going to be all right. So it's okay. It's not a problem. I think I think that is what I would like to tell them.
Okay, that's great. Thank you. And Miss Ria, can we have you back? So, patients like this, long-term survivors with a little bit of chronic morbidity. At this point, from the clinical point, a lot of doctors would have moved on because in their heads the transplant is a success. The primary disease has been cured. GVHD is something which is a consequence which can be managed, but I think not a lot of clinicians would pay attention to the mental aspect of the entire thing. So at this point, how do you approach and how do you manage to educate clinicians as well that psycho-oncology extends to the post-transplant period, and how do you deal with such patients as well?
Thank you, Dr. Rishabh, for that question. Um, so I think it's very crucial because what tends to happen is that we tend to follow these patients up in our ACT clinics very often, right? And a lot of, especially chronic GVHD, can be extremely emotionally taxing. People think they get better. They start on a bit of treatment like steroids. It gets better. It comes back. It's an up and down course, and that's sometimes very, very frustrating for patients. I think that's one of the things that they tell us the most, that every time we think it gets better, it's back, and we're not able to move on and get back to normal. So that can be extremely distressing. So for somebody who's been the primary breadwinner to now kind of give up, have to retire, it can actually make patients extremely emotionally distressed, feelings of helplessness, worthlessness, being a burden to the family. There are lots of issues that may arise. And Here, I would be particularly cautious to kind of look for any self-harm or any kind of ideations regarding, because the patient doesn't want to survive like this, right? So I would be cautious about that as well. So I think only just helping clinical teams also be aware. So some of the things that we commonly do is that in our ACT clinic, we are a team of both the medical practitioners, so the oncologist, as well as the psychologist, who do simultaneous evaluation. So we have a psychological assessment as well as a medical assessment in our survivorship clinics, which helps us to keep track of what's going on, and to address these needs simultaneously, because very often they're linked to each other. And I think this would involve, in terms of psychological treatment, would involve intensive and continuous psychotherapy, right? Because issues will evolve, and for that we will have to cater to them. So these would basically involve kind of standardized interventions which may span across weeks to cater to all these issues.
Thank you so much for that perspective. So I think we have covered a lot of points. And if any of the panelists, if there's anything which we haven't covered and you would like to add, because I know we have a lot of attendees here who I think maybe patients and families watching today. If there's anything any of you would like to add, please feel free.
Yeah, I think I would like to add that, there's a misconception around psychological care, and most people think that it just encompasses counseling or support, right? But I think psycho-oncology is very scientifically kind of informed, and the involving psychologists from the very beginning will definitely help even clinicians kind of have happier, more emotionally kind of adaptive patients, which will help them as well. So it's not a sign of weakness or a sign of inadequacy to ask for emotional support, and I think that's what we're here to be a part of. So that would be my only kind of point to add.
I think that encapsulates it in a nutshell. Uh, I would really like to express my heartfelt gratitude to all the panelists for making this so easy. I think you've taken the question so beautifully and given a lot of perspective to everyone who's been listening. So I think we could maybe close this session with that. And if there are questions, just going to stop my screen sharing.
So I don't see any questions in the chat box. Thank you so much, Dr. Rishabh, for beautifully curating this panel discussion on a very unconventional topic, I would say. And to all the panelists for letting our audience know that they are not alone in this seemingly very difficult journey, and that there are psycho-oncologists out there, there are art therapists, there are nurses like Sister Sankavi who understand what a patient is going through and who help to make their journey easier. So now I would like to hand over to Dr. Santosh for delivering vote of thanks. Over to you, Dr. Santosh.
Thank you, Dr. Silky. I would like to start with thanking Riya Daruwala for really beautifully putting together various aspects of psycho-oncology and making the point that it is not shameful or of less importance not to go to psycho-oncology from day one of the diagnosis. And I think even at our center, psycho-oncologists add real value to patient care and outcomes. I again thank Dr. Rishabh Bharadwaj for a very insightful panel discussion where various aspects of care of patients, both pediatric and adult, were discussed. And most of our doubts and questions were answered. Again, thanking Mrs. Preeti Malhotra, the parent who had a lot of important insights about her journey, and that will be useful to other family members and patients. And Sister Sankavi for her very useful insights and how she deals with patients when taking care of them for long periods of time. And last but not least, Mrs. Prasannavika for a very important contribution in terms of art and how it helps with patient care and psycho-oncology care. And again, I want to thank our sponsors, Genova and Cipla for making this possible. And we look forward to meeting everybody again, this time an in-person meeting to the ISBMT annual conference on 2nd May 2026 for our next patient support group meeting. Thank you.
Thank you, everyone.
Thank you so much. Thank you.